Who are you? What's your, really what's your superpower and why should you win this award?
I'm Brian Pepman, founder and CEO. Our superpower, I think, is being really deep in Parkinson's and understanding it really well. Parkinson's is the second most prevalent neurodegenerative condition after Alzheimer's, and it is the fastest growing with over 1.2 million diagnosed people in the US. Also, a very underserved population that is 90% Medicare eligible. We have a flagship product called Strive PD, which is an FDA cleared digital platform that uses proprietary kind of data and models that we have that are Parkinson's specific to wrap around a patient's care at home in between clinical visits, but also bridge different types of data into visits. The kind of two things that we do with that platform are offload entire elements, low risk, routine elements of people's Parkinson's care plan, as well as manage risk. We recently released health economic results from our work with Kaiser, who's one of our largest customers. We have about 10,000 patients using Strive PD every day in 150 clinics, but Kaiser is a large group. We're seeing, we released this on Monday, 43% reduction in all-cause emergency room visits. That's kind of the big top line result. There's some other good ones, but that alone represents a $4,500 annualized cost savings. And it's also just great to keep patients out of the ER because people with Parkinson's do not do well in there. And the last thing that I'll add is we have had success now with over a dozen pharma clients leveraging our network and the larger amount of data that we have and the kind of the unique data sets that we have and bridging that into clinical development at phase 1, phase 2, phase 3, and phase 4 to help folks run radically more efficient trials that can help bring some much needed new Parkinson's therapies to market.
Specific examples of how it's being used by, again, any partners, any hospital systems, anyone who you can talk, give us something specific about how it's impacting care.
In our world, sometimes it's more important the things that a specialist doesn't have to do because there just aren't enough of them. So there's 600 movement disorder specialists in the US to 1.2 million Parkinson's patients. Most patients don't even get to see one. And so the combination of kind of access and data that we have in our platform, full EHR contacts, full medication contacts, continuous symptom data sensitive to the subclinical level has allowed us to, in an automated way, serve entire elements of the care plan. So we're, in any given month, about 5% of patients, we're identifying a need for them to go to their physiotherapy appointment. We're helping them close the loop on getting that appointment and verifying with them on the back end that that actually helped. About 5% of folks we're flagging that they're having some kind of hydration and diet issue that's interfering with their primary med uptake and increasing their symptom burden, and we coach them through that. So these are things that are low risk, routine, but nevertheless do clog up the workflow of a specialist. And by removing that, we're opening up specialist time, but we're also serving these things on demand to folks so they don't have to wait for their specialist to go see it. I think that's something we're really happy with. It also, because we're monitoring these folks, I mean, and these are like the really clear ones, about 2 to 3% of folks in any given month, we get flagged as super high risk. They're having an acute increase in symptom variants, falls, certain patterns that we know are associated with really high risk. There was one woman in particular who comes to mind who we recognize some of these patterns, these high variant symptoms. And what we're able to do, because we're opening up capacity, is triage her for a visit to her specialist. And so she goes in, and it turns out that she was sick with another illness that was interfering with her ability to take meds. And she was going to be in a fairly dangerous position based on her symptom burden, have a fall, possibly end up in the ER, possibly end up in the hospital. Fortunately, she was able to get to the specialist in that case, who was able to assess that and change up her meds such that she did not have those same dangerous symptoms when she came back and did not end up in the ER. So that, yeah, it's kind of two sides there.
And let me just follow up with one question for you. So, you said you've got, is it over 1,000 patients a day using it? Is that right?
10,000.
Sorry, 10,000. I was off by a very big important digit. So 10,000 patients a day using this. You gave a good example right there of, identifying somebody who's super high risk. Are those patients who are using this daily? Are they ones who are there physicians driving the behavior, or are the patients on their own adopting this?
Yeah, our system works. There's a relatively close analogy to like an insulin management system that uses a continuous glucose monitor. So most of the coaching and data we're just delivering to the patients on their own and doing it in a way that's friendly to them, where we can interpret as much as possible, where they can take the actions they can take. And when we take the steps to connect to clinical care, or when it gets complicated or high risk, or it's something that their care team has like specifically asked for or specifically in their care plan. So 95% of what we do is with the patient and their caregiver. But that other 5% is still really important for those special cases.